Good evening, everyone, and welcome to the Medical Cannabis Science, Safety, and Shared Decision-Making webinar. My name is Rebecca Gillett, and I am the Director of Content Strategy and Planning at the Arthritis Foundation, and also the co-host of our Live Yes with Arthritis podcast. But most importantly, I'm an arthritis patient just like you, and I have been living with both rheumatoid arthritis and osteoarthritis for almost 20 years. Our guest experts tonight will help us understand the science, safety, and effectiveness of using medical cannabis for mediation for arthritis pain, as well as discuss how to safely use medical cannabis and how to determine if it's a right option for you. Personally, I've talked about this before in our CBD podcast episode, but we actually have a podcast episode that just came out yesterday with one of our guests today on the webinar as a guest on there to talk about it. And I shared a little bit of my personal experience on trying some topicals and things to try to help manage some of my pain. And so everybody has a different journey with pain. Some of us have had this for many years and are still trying to find something that works really well. But the most important thing is that you go in knowing what you are about to do and communicate with your doctor, know what your options are and what the safest options are. And so that's why we have our guests joining us today. And we are so excited to have both of them to help enlighten us. I know I've learned so much about it from Dr. Boehnke, who's one of our guests this year too. So before we get started, I'd like to share this short video about our Insights program to talk a little bit, show you a little bit more about that and how you can help shape the future of arthritis.
By taking part in the Live Yes Insights assessment, you help change lives today, including your own. And you help change the future of arthritis. It takes just 10 minutes or less to share your experience and make a difference. Answer simple questions like how often you felt arthritis pain in the last week. Ongoing insights data from people like you will lead to new resources that ease daily life. Your insights show what kind of support you need in your community. You improve the healthcare system. You focus researchers and others on top priorities. You'll make more research funding possible, leading to new groundbreaking treatments. The power is in your hands to change things now and for the future. This is your opportunity to change the future of arthritis.
All right, so tonight's event is partly in the reason we do these events is because we get feedback from you. And our Insights program helps drive and inform the patient education that we do provide, and we're able to get more information and get the best experts on with us to help educate you in making your treatment decisions. Our goal at the Arthritis Foundation is not only to raise awareness about the challenges of living with arthritis, but also to collaborate with our health leading experts to provide strategies and support that can help you thrive. So the Insights program really does help us shape the program we do. And one of the things that came out of that in 2019 was pain. And so many people are in pain and trying to find options that actually work for them after years of trying different things. They're looking for alternative options. So that's a great reason that leads us to our event today. So if you have not completed the Insights assessment, we encourage you to go ahead and fill out that survey. Just before we get started, there's a few housekeeping items I want to go to. We have muted all attendees for this event, but you can direct any questions you may have throughout the presentation in the Q&A box at the bottom of your screen. We will reserve time to answer your questions during the presentation and at the end. The webinar is going to be broken down into two different parts today. The first part will be led by Dr. Kevin Boehnke, Research Investigator, Anesthesiology Department of Chronic Pain and Fatigue Research Center at the University of Michigan. He's going to help us understand the basics of medical cannabis, as well as the evidence behind its effectiveness for various chronic pain conditions and offer practical tips for use and safety. And in the second part, we'll have Dr. Mary Ann Fitzcharles. She's a rheumatologist and pain medicine physician at McGill University in Montreal. And she's going to help us understand the current role of medical cannabis in arthritis management and the importance of talking to your doctor if you're considering or currently using medical cannabis for your arthritis. After tonight's session, you'll receive an email about your experience tonight. These surveys help us track how the success of these sessions are and better plan for other events in the future. So please take a few moments to let us know what you think. Let's get started tonight and introduce our first guest speaker, Dr. Kevin Boehnke. Dr. Boehnke is a research investigator in the Department of Anesthesiology and the Chronic Pain and Fatigue Research Center at Michigan Medicine. He studies medical cannabis, chronic pain, and self-management strategies for pain, such as yoga. He currently leads several studies examining the effects of cannabis and cannabinoids on chronic pain. Dr. Boehnke, welcome. It's great to have you on our webinar this evening. Thanks for joining us. Dr. Boehnke has been a guest 2 times over now on our podcast. So welcome to our patient education webinar, Dr. Boehnke.
Thanks so much for having me. I'm delighted to be here. So just wanted to put it out there. I do this for every talk. Couple disclosures. So I sit on a data safety and monitoring committee for a clinical trial with Vero Health in an unpaid capacity. And I'm also supported through an NIH grant through the National Institute on Drug Abuse. Next slide, please. And so what I want to do is, provide this big picture overview of what is of the terms associated with cannabis. So you've probably heard hemp, cannabis, marijuana, medical cannabis. Well, what's going on here? What's the difference between these terms? So basically, all of them are cannabis sativa. They just happen to have different properties, or their names come with different historical or scientific contexts. So hemp refers to cannabis sativa that has less than 0.3% THC or delta-9 tetrahydrocannabinol, which is associated with the high that you think of when you think of the cannabis high. So this very small amount of THC in there basically has pushed the legal status of hemp products into out of the Controlled Substances Act. I'm getting a little, my headphone mic is rubbing on my shirt, excuse me. Moved it out of the Controlled Substances Act. And so these hemp-derived CBD products that you see all over the place in the supermarket, at the gas station, online, they're typically derived from hemp. Now, marijuana, which is another term for cannabis and also is often used in the medical marijuana laws, designates cannabis that has more than 0.3% THC. And it's a term that has often been used historically in cannabis prohibition campaigns, which have typically had a racist and xenophobic bent. So I prefer not to use that term. And then lastly, cannabis. This is the most accurate scientifically. It's the least offensive term, and it's all encompassing as well. So that is the term I'll use moving forward. I also just want to note that although the laws certainly call cannabis medical at this point, it's not medicalized in the sense that you would expect a typical medication to be, as in none of the products that you can find in a dispensary have actually gone through the rigorous FDA approval process. Next slide, please. And however, some of the products that are found in cannabis, or cannabinoids, which are some of those active ingredients, are actually available as FDA-approved medication. So I already mentioned THC, which is analgesic, mood altering, and appetite stimulating. It's available as Marinol or other similar medications as a Schedule III medication. Cannabidiol, or CBD, is non-intoxicating. There's a lot of excitement about CBD, both because it was recently removed from the hemp-derived CBD products were recently removed from the Controlled Substances Act. So they're widely available. They do not get you high. And in fact, there might be some potentially protective effects of CBD on the psychoactivity of THC. We know from clinical trials with Epidiolex, which is an FDA-approved CBD product, that it is a strong anticonvulsant in childhood epileptic syndromes like Dravet syndrome. And there's some evidence that it might be useful against anxiety, although that's a slowly growing research space. And in non-human animal studies, there is some evidence that CBD is a potent anti-inflammatory, but unfortunately, those data have not been translated to humans. Next slide, please. So at this point in the US, numerous states, I think 35 at this point in Washington, DC, have legal medical cannabis programs. Nearly a dozen have legal adult use or recreational cannabis programs. Next slide, please. But this is in spite of cannabis remaining a Schedule I substance. So in this case, I'm referring to cannabis that has more than 0.3% THC. And this designation has had a lot of repercussions. So most importantly, on the criminalization side, the criminalization of cannabis since the 1970s through the Controlled Substances Act has caused many, many people to be arrested, incarcerated, families broken up, immense amounts of societal pain associated with that criminalization, and that has disproportionately fallen on Black and brown and poor communities. So an ongoing set of injustices associated with that designation. Further, when we go to the scientific side of trying to provide you all and other people who want to use cannabis as medicine with useful information, this Schedule I status, according to the Controlled Substances Act, means that cannabis has no accepted therapeutic uses and a high potential for abuse, which we know simply is not true, just based on the previous slides I showed you, where there's FDA-approved medications for nausea and vomiting in the case of Marinol, and then for seizures with CBD. So this mismatch has really hampered the science. Next slide, please. And I will say as well, because of this mismatch from the state and federal level, it means that these state programs have so many different products available, and I'm sure you've seen these both in the CBD space, where this photo is from, but if you've been in a cannabis dispensary, you'll see there's anything from edibles to tinctures to capsules to vape pens to smokable flower. Next slide, please. So then if we look at how cannabis products or cannabinoids, the active compounds in cannabis products, work in arthritis in clinical trials, unfortunately, the evidence is quite sparse. So there are 3 studies that have been done in fibromyalgia. 2 of them use nabilone, which is similar to THC. It's synthesized in the lab, showing improved pain and sleep, but these were small studies. There was a 3rd study that actually looked at a single inhalation of cannabis and found some pain relief with a CBD plus THC combination. But unfortunately, this doesn't really translate especially well into a chronic pain management context. In rheumatoid arthritis, there's a single clinical trial using Sativex, which is a sublingual 1-to-1 CBD to THC spray that's available in many countries, but not the United States. And in this small and generally low quality study, they did show some positive effects on pain and sleep, but that research program hasn't moved forward very much, and that's the only study we have in that indication. In osteoarthritis, similarly sparse data with one novel cannabinoid compound that showed no effect at all, and then a recent clinical trial with CBD, which is promising, showing some positive effect on pain and function, but it's not been peer reviewed yet. So we're waiting to see what will happen once that goes through the scientific peer review process. Next slide, please. We do know, of course, that cannabis, like any other medication, does have risks. It does not cause lethal overdose in the same way as pretty much any other medication. To my knowledge, I have not heard of any cases of a lethal overdose from toxicity due to cannabis. That doesn't mean you can't die while making poor decisions, like getting behind the wheel of a car while intoxicated. In the long term, there's also respiratory effects of smoke. There's risk of dependence and addiction, especially when people start at young ages and adolescence. And there's some evidence suggesting that there may be a slightly higher rate of psychotic illnesses developed, especially with use under the age of 25. In the short term, some common side effects include dizziness, somnolence, anxiety, and others. Less commonly are things like vomiting, paranoia, and seizures. And I think one of the big things to be thinking about is the quality of the cannabis product, especially for illicit products or CBD. So for illicit products, they probably haven't been tested at all, and so they might be contaminated with pesticides or things like cannabis mold, which you can see in the picture of the cannabis flower up top. And because CBD, while it was removed from the Controlled Substances Act, is largely unregulated, there's a lot of people who don't know what they're doing making and hawking CBD products. And those have been shown to contain anything from heavy metals to pesticides to residual solvents. Next slide, please. Add to this complex picture is a lot of people will report substituting cannabis for many pain medications. These are some data that I and my colleagues collected. A lot of people reported substituting cannabis for opioids and stopped using or decreased their use of opioids, benzodiazepines, and many other pain conditions, pain medications as a result. But unfortunately, the substitution typically happens with no physician knowledge or delayed physician knowledge. So people are kind of going it alone without building that positive relationship with their physician. Next slide, please. So what I want to do with my last couple slides is then just provide a little bit of practical information about using cannabis, as my colleague Dr. Fitzcharles will focus more on building that relationship with your physician. So I just want to break down some of the administration routes. So inhalation through smoking or vaporization has a very quick onset, 5 to 10 minutes, only lasts a couple hours, 2 to 4 hours. There's some data suggesting that this can be helpful for breakthrough pain, but smoking we know is not a good choice if you can avoid it. And so I caution people away from smoking and vaporization. Now, it can be taken by an oral route as a capsule or an edible. I put in a picture of a typical edible that can be found at a dispensary, which is sugar infused. I'd stay away from that as well. Probably go with a pill if you can. And these take 1 to 3 hours to hit and last a lot longer. But with these, it's very important to not take too much because of that delayed onset, you can get an overwhelming feeling much too late in the game. Tinctures are, in fact, the thing that I think are probably the best choice if people are thinking of using a cannabis product, because they're in the middle in terms of effect onset, 15 to 45 minutes. They last quite a long time, and they're easier to dose as you can do a single drop at a time. Topicals, unfortunately, we know very little about how long it takes for them to take effect and how long they last, because the formulations are so variable and there's so little data. Next slide, please. So in terms of then how to think about using cannabis and practical tips associated with it, given this complex landscape, we know that the clinical trials are limited and patients are using cannabis regardless. So effectively communicating with your physician and with other members of your treatment team is super important. So coming up with a treatment plan with them. In terms of dosing, unfortunately, there's no medical dosing guidelines that we can draw from. So a lot of it is safety and harm reduction based. So start low, go slow, taking a very small amount at a time, like a single drop of a tincture, for example. And you can also think of this in terms of THC versus CBD. If you start with CBD alone, you don't have that potential intoxication effect. So going with CBD or a high CBD, low THC product is a good way to begin. We already talked about administration routes. And I will say that looking at the data of cannabis versus opioids in the chronic pain context, we know that opioids are not particularly effective for most people with chronic pain, and they cause a lot of negative side effects. And in fact, there's, as I'm sure many of you know, the ongoing opioid crisis causing tens of thousands of deaths each year. So both on the safety side and then on the usefulness side, cannabis is probably a more therapeutically valuable option than opioids. There are some legal concerns. If you are employed, these products, even CBD products, may cause a positive drug test. So that's something to consider. And then THC, I just want to note here that if you do not live in a state with medical cannabis, you probably cannot obtain THC except through those either illicit source, which I would not suggest, or as FDA approved Marinol or Dronabinol. But if you live in a state with legal medical or adult use cannabis, you can get it through a licensure through a physician, or just go into an adult use dispensary. So with that, I thank you all for your kind attention and look forward to hearing from Dr. Fitzcharles. Next slide, please.
Thank you so much, Dr. Boehnke, for that. I know you are a wealth of information. I have learned so much from you. Hopefully everybody else has as well. And again, we've had a couple conversations with him to learn more about CBD and medical cannabis. If you want to tune into the websites, he goes into a little bit more depth about at what point it's which different topics of when you might want to explore it. So excited to have Dr. Fitzcharles now with us so that she can talk about how to communicate well with your doctor. So Dr. Fitzcharles is an associate professor of medicine in the Division of Rheumatology in the Allen Edwards Pain Management Unit at McGill University. She has been on faculty at McGill University since 1984 and is a founding member of the Royal College of Physicians of Canada Pain Medicine Specialty. Over the years, she has focused her clinical research on understanding the experience of pain in the rheumatic diseases, and she has had a particular interest in the use of cannabinoids by persons with rheumatic conditions. Dr. Fitzcharles, welcome, and thank you so much for joining us tonight.
Thank you, Rebecca, and good evening to everyone. So let's get going. Next slide, please. So I'm going to give you a little bit of insight into the Canadian experience of medical cannabis. Next slide, please. So cannabis, medical cannabis, has been available and used for thousands of years. We have evidence that it's been used for more than 5,000 years. It still is one of the 50 traditional herbs in Chinese medicine. And it's used mostly for pain, for inflammation, to help with sleep disturbance. And very interestingly, you could have bought it over the counter in the US in the 1900s, as you could have also bought opioids over the counter. And some very famous people have either used cannabis or they've advocated the use of cannabis. So Queen Victoria, between all her pregnancies, had apparently a lot of menstrual cramps, and she used cannabis for her menstrual cramps. And Sir William Osler, who is a great father of medicine in both Canada and the United States, stated that cannabis was a very, very good treatment for migraine headaches. Next slide, please. So let's turn to Canada and what lessons can be learned from Canada. So we have had medical cannabis available since 2001. So we've had 19 years experience with medical cannabis. And the way in which patients can access cannabis is they can access a document, not quite a prescription, but a document from their physician. It is then sent to the grower, and the cannabis is posted to the patient. So it arrives in the post. Since 2018, we've had recreational legalization, which means that most people over the age of 18 in most provinces can walk into a store and just buy cannabis. So cannabis is a huge, huge market. The combined legal and illegal market in Canada is $6 billion. But only 1/3 of that is the legal market. So 2/3 of the market is still illegal. So in Canada, you can go into a store and buy a gram of cannabis. So most people who are using cannabis, either recreationally or even medicinally, use about 1 gram to 3 grams a day if they're smoking. A gram costs about $8, but you can buy it on the street for $5 and maybe even less. And we also know that about 15% of Canadians have used cannabis in the last 3 months. Next slide, please. So what are our rheumatology patients doing in Canada? And we surveyed 1,000 rheumatology patients in Montreal after cannabis was legalized as a recreational product. And what did we find? That medical use has tripled in 5 years. So we did the same survey 5 years ago when it was only a medicinal product available. So as soon as we had recreational legalization, the medical use tripled. So 13% of our patients had tried medical cannabis, but only 1/2 continued to use. And I think this is important. And it speaks to the fact that cannabis doesn't necessarily work for everyone. But exactly as Dr. Boehnke cautioned, only 1 out of 5 patients accessed their cannabis entirely via the legal medical route. So many of our patients were accessing cannabis via the illegal route. And the concern is that we really don't know what they were taking, and they don't know what they're taking. But I think this is probably being driven by cost. And also of great concern to us was that only 1 out of 3 patients had disclosed their use to the rheumatologist. And this is so very important when we're caring for patients. We really do need an open, empathetic relationship with our patients. We want an open dialogue. And it's really concerning to us when there has been non-disclosure. So next slide, please. So medical cannabis may have some effect on pain, and that is probably the most common reason that patients with rheumatic complaints use cannabis, but it might also have some effect on sleep difficulties and mood, particularly help with anxiety. Next slide, please. So the Canadian College of Family Physicians has made a recommendation on the basis of the evidence, and Dr. Boehnke showed you that there's very little evidence, good, sound, scientific evidence for cannabis use in rheumatic conditions. And the College of Family Physicians in Canada have said cannabis should not be used by patients with rheumatic conditions. Now, it's a little bit like putting your head in the sand, like the ostrich, denying that it is something that patients have an interest in, that patients are trying. So in that context, we'll move to the next slide, please. The Canadian Rheumatology Association mandated us to develop a position statement, which we've published as a pragmatic approach for medical cannabis use in patients with rheumatic diseases. Next slide. And the overarching principles of the Canadian Rheumatology Association position statement on medical cannabis is the primary goal is do no harm. So as Dr. Boehnke noted, there are acute effects and the long-term effects are essentially unknown. So we must be very cautious that we do no harm. Another point is that medical cannabis is not a substitute for standard medical care. And we've seen patients with rheumatoid arthritis who have been on disease-modifying agents and who have been convinced to drop their standard treatments and use medical cannabis. And this is not what our patients should be doing. We also acknowledge that there is very poor evidence in the literature for effect in rheumatic diseases, as Dr. Boehnke noted, but there may be some benefit for some patients. We also were very definitive that we stated that we should not recommend use of medical cannabis for people under the age of 25 years. And where does this come from? Well, the human brain continues to develop and to grow until we're in our early 20s. Boys take a little longer to mature and develop, up to 25, women maybe a little earlier. But this developing brain can be greatly impacted by cannabis because we've got endocannabinoids in our body. We've got endocannabinoid receptors. And these endocannabinoids are very important for developing good nervous system circuitry. So we really have great concerns if younger people are using cannabis. We acknowledge that there are short-term side effects, they're common, and we really worry about someone feeling a little bit dizzy, losing their balance and falling, and breaking a limb. We also are concerned about cardiac effects, and there's increasing evidence that there might be some cardiovascular risks. And exactly as Dr. Boehnke said, long-term side effects are largely unknown. But we've also emphasized that the physicians must maintain an empathetic therapeutic alliance with their patients. Next slide, please. So our contraindications are not for people under the age of 25. Those clearly with allergies, pregnancy, breastfeeding, psychosis. But we've advised caution for the elderly. And we really worry about an older person who might have a little bit of cognitive problems, who might be on an agent that can possibly have some psychoactive effects, such as perhaps an antidepressant, or perhaps taking a sleeping pill and then adding cannabis to this. So we worry about the elderly, those with unstable mental health. And we've certainly seen, we believe that cannabis can help with anxiety, but we've seen patients become very anxious with cannabis. So cannabis is a funny set of molecules. In one person, it can cause them to be very sleepy, and in someone else, it can induce anxiety. We advise caution for those with cardiovascular or pulmonary disease, and also for people working in settings that require concentration, executive function, and alertness. And we have caution regarding concomitant sedatives or psychoactive drugs. Next slide, please. So there's a lot of interest in CBD, and we have a lot of basic science evidence that CBD might be a very good product for reducing inflammation and impacting pain. But we honestly do not know in the clinical world whether this is true. There are a lot of artisanal products out in the market. You can go to the corner store just about. You can buy enriched products, and enriched means they've got a little bit of addition of things like cinnamon and cloves, turmeric. Turmeric is supposed to have anti-inflammatory properties. You can get pure or boosted CBD. Boosted CBD means that it's got more than the natural amount. They've put extra CBD in it. Or full spectrum, it contains some of the other molecules that we find in the cannabis sativa plant, such as terpenes and flavonoids. But the FDA has issued considerable warnings to these CBD vendors because of mislabeling of the product and also not telling us what really is inside the product, and also with additions, as Dr. Boehnke noted, heavy metals, etc. So what truly is in the green bottle? And there have been studies done showing that sometimes only 30% of the CBD products that have been tested are accurate in regarding their labeling. Next slide, please. So some tips if you're thinking of using medical cannabis. Inhalation should be strongly discouraged. Rheumatic disease patients or people with rheumatic diseases should not be smoking anything, cigarettes or cannabis. We do have some concerns about vaporization because there has been very severe respiratory disease related to vaporization. It's not quite clear exactly what the reason is. But again, I support Dr. Boehnke's recommendation that taking it orally is much, much safer. Get the medical cannabis from a legal licensed source with the known amount or the known molecular content. Be very cautious about getting advice from non-medical persons, such as advice from your next door neighbor or even those working in dispensaries. And we know that many people working in dispensaries and giving advice, medical advice regarding cannabis use, have no medical training. Again, if you're thinking of using cannabis, choose a product with a very low THC and a higher CBD content. And again, the ideal dosing schedule is really and truly not known. But in Canada, it is recommended that you should not be using more than 3 grams a day. Next slide, please. So how to talk to your doctor about medical cannabis? And there are some physicians that simply say, no, I don't want to go there. And you really want to maintain a good therapeutic relationship with your healthcare professional. So perhaps you could open up the dialogue by explaining which symptoms you hope to help. You can discuss what you've tried and what has worked or what has not worked. What have been the positive or negative effects? We see so many patients that really have quite severe side effects from even very small amounts of medications, such as the gabapentinoids. Report honestly about the following. If you are using opioid medication, report exactly how you do use your opioids. Are you using them as prescribed? What is your current mood? If your mood is really down, if you're depressed, maybe this is not the time to be considering introduction of cannabis. Report on your alcohol use, because we know that a combination of 2 substances that can have psychoactive effect can have an additive effect. And also be honest about your previous and your current cannabis use, and let your physician know whether you're using any street drugs. And if the physician has concerns about medical cannabis, ask to please have these explained to you. Is this because the physician has a personal bias, or are there some factors in your medical status that causes the physician to have concerns. Next slide. So some take-home messages. Medical cannabis may help some patients. If you are going to try it, only continue to use it if you are certain that there really is a benefit. Otherwise, you're just going to burn a hole in your pocket. Always inform your physician about what you're taking. Be honest. We are so grateful when we have an honest, open dialogue with our patients. Always obtain the cannabis from a regulated source, never on the street. You don't know what's in the stuff. And do the best you can to know the THC and the CBD content of what you're taking, as well as the amount. Look at this and treat this as you would any other medication. You know the number of milligrams of an agent that you're taking. And again, it's not a good idea to take a bite of a brownie and say, this is my medication, or to pop a few gummy bears and say, I'm taking a medication. So really and truly, think of it and treat it as a medication. Try to know the molecular content and the dosing that you're taking. And I think with that, that is what I have to say.
Thank you so much, Dr. Fitzcharles. That's very helpful information. Especially, I applaud how Canada has put out a statement and said, people are using it, right? So let's have that conversation with your doctor. And one of the things that we really want to make sure we do is have that open, honest communication with our physicians, and let them know if our treatments are working, whatever it is that you're using to help manage your pain. If something's not working, you have to communicate with your doctor and open up that dialogue. Before we start into our Q&A session, part of this program, we're going to take some time to answer some patient questions. We received a ton of questions about costs and legality. So please note that medical cannabis products are not covered by private insurance or Medicare unless prescribed by your doctor for an FDA-approved condition. The laws governing the use of medical cannabis in each state varies, and it's so important that you understand the regulations in your state. Every state's different. Look up your state laws. Find more information at the website listed on the screen, or contact your state health department for more information. So with that, I'd like to also refer you to the Arthritis Foundation has the CBD guidance for adults with arthritis that has information too on how to look for a quality product and give you some guidance with that. So we'll now go toward our questions for the evening and bring back Dr. Boehnke and Dr. Fitzcharles for some questions. So before we head into some of these questions, one question that everybody kind of wants to know, and that we're getting some questions in the chat. I'll throw it to you first, Dr. Fitzcharles, is what's considered the safe minimum and maximum dose for one CBD, and then for only doing CBD THC combo?
So the honest answer is we honestly do not know. So if we think of CBD, there currently are many studies ongoing that have been registered with clinicaltrials.gov. And these trials are using CBD amounts from 10 milligrams a day up to a few thousand milligrams a day. So there's a huge variation in CBD concentrations that are currently being investigated. Generally, and we can get some idea of what type of concentrations of molecules might be used by referring to the nabiximols, which Dr. Boehnke mentioned, This is the spray of a mixture of CBD and THC that you spray into the side of your cheek. And these sprays contained about 2.5 milligrams of CBD, 2.5 milligrams of THC for each spray. So extrapolating from that and how many sprays were considered to be reasonable, up to 8 sprays a day, one generally says that maybe 25 milligrams or 30 milligrams of CBD, 30 milligrams of THC might be the dosage amount that we could use for patients with rheumatic diseases. But I will bring your attention to the fact that if you get a bottle of CBD, it usually is about 300 milliliters, usually 10 milligrams per milliliter, and 1 drop is 0.5 of a milliliter. So if patients are taking just a few drops, they are taking very, very low amounts of CBD. And my question often is it really the CBD that's working? Or is there perhaps a placebo effect? And if there is a placebo effect, I have no problems with that if the patient is doing well. But many of our patients are using really very, very small amounts of CBD.
Thank you for that. Dr. Boehnke, do you have anything you might want to add to that question about a safe minimum or maximum of either CBD or a THC CBD combo?
Yeah, so I think Dr. Fitzcharles did a really nice job covering it. I think the only thing that I would add on the THC side is it can be instructive to look at what dose of THC, but what the minimum dose of THC is. Synthetic THC products are sold in the U.S. in those FDA approved products like Marinol. So the minimum dose for those is 2.5 milligrams. That's for a different indication. It's for chemotherapy-induced nausea and vomiting or wasting and AIDS associated with HIV and AIDS. But I think that that's something that the FDA has said, okay, this is a reasonable starting point. So I think that's something either at or a bit below that can be a good point to start if people are introducing THC. I did just want to add one thing back to the clarification at the end of the slides about insurance coverage. Is that refers to FDA approved medications that are cannabinoids. It does not refer to products that you buy in a dispensary. Those products, to my knowledge, in the United States, you will not get insurance coverage for. There are some companies and states that are looking into figuring out how that might happen, but to my knowledge at this point, there's not going to be insurance coverage. Even if you have a doctor recommendation, they can't actually prescribe medical cannabis products at this point that are not FDA approved. So they give you a recommendation saying this, you have a condition that qualifies you to use medical cannabis under state law.
Okay, that's helpful to know. So only FDA approved drugs that are prescribable would get potentially covered by insurance. So, yeah. Okay, great. Well, thank you for clarifying that point as well. And I know I've learned so much from you. Start low, go slow. I mean, that's kind of, and one of the things I know that you've mentioned before to us in a podcast is, start with just a CBD product and go from there to see how that helps if you are wanting to explore that option. So I have a question.
Could I just add one little extra point about start low, go slow?
Yes.
So what we generally tell patients is if you're going to start with a nighttime dose and be at home. Don't plan to go out. And if it's an older person, I really would be very happy if there's someone else with them. Have your supper and have a small nighttime dose just to see how you respond. And we've had patients that have had a tiny, tiny dose and have said, just awful. I felt completely bad. So don't plan to take it on a Monday morning and go off to work. Start with a nighttime dose, and then maybe on a weekend, if it really has given you some good effect, then maybe try a tiny dose in the mornings to see how you respond during the day. Because we really, even the CBD has got a little bit of THC in it. It should have less than 0.3%, but it is a little bit.
Yeah, very good point. And I love your suggestion. Started at night and maybe on the weekend if you're gonna try a little bit more just to see how it affects you and it doesn't interfere with your work or school or whatever you're doing during the week. So Dr. Boehnke, I've tried some CBD products like topicals and a tincture, but didn't necessarily work for me. And this is a question that somebody is also asking, but I can relate to this. Are there certain strains or ratios of CBD and THC that might work for different issues? So when I tried, I wanted to try it for sleep. I know some people want to try it for their anxiety that having a chronic disease can bring on to you. Is there something that you would say is a little bit more effective for that?
Yeah, I think you pointed out a really good lesson within there, Rebecca. So the idea of the symptom guiding the product use and the choices made around that is something that we can all be more thoughtful about, I think. So as Dr. Fitzcharles mentioned, trying it out at night, that's a really great idea, especially because so many people who are having pain-related issues also have sleep issues. And if you have a better night of sleep, we know that typically your pain and other symptoms, including anxiety, will often improve. So, and we also know that pure CBD at nighttime might not be the best idea because it can be a little bit uplifting and not necessarily helpful for sleep. Well, that's a time that having a bit of THC can be more helpful. In terms of daytime use, I think that's really also a time that CBD is a good thing to lean towards because you don't want to have intoxicating effects. And if you were going to use it in the daytime, that's a way to stay safe and keep the people around you safe, especially if you have to operate a vehicle or something like that. So the symptom guiding what you use, I think, is an important thing. In terms of ratios, which was the other part of the question, I believe I firmly believe that that high CBD, low THC ratio or pure CBD is going to be a great place to begin. But you live in your own body, and as you are experimenting with, because we don't have those types of specific dosing guidelines to give you, you may find out, okay, I found my sweet spot for CBD, fantastic. But that sweet spot might change and you might have to experiment and figure out as time goes on how your symptoms and are evolving and whether or not cannabis remains a useful choice for you. And that's something that, again, really is important to work with your physician about, because if you're doing something like tracking your symptoms, for example, and you notice, okay, CBD alone is doing great for my pain, but I need something for my sleep, then you have some data to take back to your physician to report to them. But if you're going at it in an unsystematic way, then it can be very difficult to actually know what is helping and what is just contributing to background noise, so to speak. And then lastly, the point about strains, like strain names like a purple kush or something like that. Unfortunately, these names are all over the place. They may have at one point referred to a specific, genotype or phenotype, but people have put names on so many different things that it's really unclear what those actually signify. And there's a huge body of research looking into some of their compounds responsible for taste and odor, terpenes and flavonoids. but we've barely scratched the surface in terms of how those might interact with THC and CBD.
Yeah, thank
Could
you.
I add just a little comment
Yeah.
about topicals?
Mhm.
As Dr. Boehnke didn't is that bit of your question. And topicals are something that is very, very attractive, certainly to rheumatologists as well as to our patients. And the cannabinoids are what we call lipophilic substances. So they're fatty substances. And so for the cannabinoid to be able to penetrate through the skin and to get down into the joint, it's got to have a carrier molecule that sort of pulls it down. Because if you put nice hand cream on your hand, the hand cream doesn't get into your joint. It stays on the surface of the skin. And we honestly do not know whether these artisanal products have got or are compounded in such a way that they have a carrier molecule that can bring them down. So the study that Dr. Boehnke presented about osteoarthritis of the knee, they actually did have what they call an ethosomal carrier molecule. So we know that the stuff actually did get down. But everything, all of these creams that we can buy, we honestly don't know whether they've got the carrier molecule.
So how, if you were purchasing a product, is there a way to know that it would have that carrier in it? No.
I don't think so. Do you, Dr. Boehnke?
I've seen a lot of products that make claims saying that this is a transdermal product that will lead to systemic absorption, but that doesn't mean they've had that tested in any rigorous way. So in some ways, I would be even more skeptical of those types of products, because then they're making a more medical claim when they, and if they don't have data to back that up, that means that they might, just be someone who's unscrupulously trying to make as much money as possible while getting as good.
It might be that a little bit of stuff does get in, and maybe just a little bit of stuff in a local area might be good for some people.
Yeah, right. Yeah. And again, I think you made that point, Dr. Boehnke, and I've heard you say it before, is that you as a patient are the expert of your own body. And we all know that we all respond differently to different medications and treatments. And so being able to have that open conversation with your doctor, like what symptom am I trying to target, that I'm not finding relief from anything else that is making me want to explore and bring up this topic, right? So I appreciate you saying that, because I know a lot of patients don't feel like they are able to have that open conversation with their doctors, or that they don't feel the doctor respects that this is my experience and I don't feel like this is working for me and I want to find something else. So thank you for saying that. One of the other questions I have, Dr. Boehnke, are what are some of those red flags that I should look for when buying a medical cannabis product in terms of quality?
So medical cannabis products are in some ways different from CBD products. So the medical cannabis products in the States, and again, you'll want to look at your own state regulations. But for example, in Michigan, where I am, those products have to be tested for potency. They have to be tested for certain contaminants. You can find the list on the website. CBD products, by comparison, do not have any kind of, that kind of stringent regulatory structure in place. And so I think those are the ones that we'd have a lot more concern about. Red flags, I'd say, for CBD products would be more, making those types of health claims. For medical cannabis products, honestly, I've seen, unfortunately, like many of these products make health claims on them, or the people selling them to you will make health claims. But it's unfortunately a space where I've seen personally that you have to do your own research and look at what the state requirements are. But I will say that, buying a product at a medical cannabis or an adult use dispensary is typically, and I don't know why I said typically, would pretty much always be safer in terms of more about what's in it than if you buy an illicit product that doesn't go through that supply chain. Dr. Fitzcharles, do you have anything you want to add to that? I know you know so much about this space.
So I absolutely agree. Get it. So certainly in Canada, we've got regulated growers, and I think in most states in the US, you do have regulated growers. So one has a much better reassurance that what is labeled is correct. And we know that, you mentioned that, you can have the same strain that is grown indoors or maybe outdoors, and the molecular content will be different. So the cannabis plant is a plant. I love to garden, and if I plant a plant in one little area of my garden, it doesn't get enough sun, but if I move it somewhere else, it's beautiful and happy. And this is exactly what the cannabis sativa plant does. So even although you've got the same strain, the growing conditions might be different. The way in which it's stored might be different. So there are patients that have told me, I got this exact same strain and I got it from the regulated grower, and it's just not the same. So there is a reasonable explanation. There's a botanical explanation why it's variable. It's a plant. It changes.
Yeah, and we can't control that, right? Just, like you can't control the weather. So I think one of the things that people who are exploring and wanting to know is there a different treatment option? Is this right for me? The biggest question everybody has is, we know there's not enough research. There's a huge lack of research in this area, especially here in the US. But is there any research or information about potential drug interactions? Because we're all on some pretty, pretty hefty medications when we're managing arthritis, especially if it's an inflammatory type. Is there any information or research about interactions between medical cannabis and the biologics or blood thinners and anxiety medications? And I will throw that at you, Dr. Fitzcharles.
Right. So there are theoretical considerations regarding interaction because of the way in which the cannabinoid molecules are metabolized. So depending upon whether it's THC or CBD, there is the potential to increase the effect and increase the blood concentration of some of the anti-epileptic agents, such as the gabapentinoids. There is the potential to increase or even decrease the blood concentration of some of the antidepressants. So this is potential. There is the potential that cannabinoids, particularly THC, might reduce the blood concentration of some of the blood thinners. And the only biologic or the only disease modifying agent that might have potential to interact with cannabinoids is tofacitinib. And tofacitinib, which is used to treat rheumatoid arthritis, might have its concentration increased. But again, it's a theoretical potential. More practical is the combination of psychoactive drugs or medications with cannabis. And the psychoactive medications are those that you can take and you can say, oh, I just feel a little woozy, such as the gabapentinoids, some of the antidepressants, opioids, absolutely, and substances, alcohol.
Okay, thank you. I know that's a huge question, being afraid to try something different to treat pain when you're not sure how it's going to interact. And again, we're behind the 8 ball on research, so we don't really have all those answers per se. But one of the things also, when you are on biologics or a lot of medications, whether it's for other conditions as well, is, how is this going to affect my internal organs, Dr. Boehnke? So do we know about any cannabis effects on internal organs, such as heart, liver, or kidneys? I know a lot of people in our community might have, if they have issues with kidney issues, or, we're always having to get blood work to check our liver when we're on biologics. So could this have any effects on that as well?
Yeah, so as Dr. Fitzcharles mentioned in her talk about the potential cardiac effects, so in some people especially use of THC, could cause an increase in heart rate. That does seem to be dose dependent. So in some people it may cause an increase in heart rate, especially if there's an anxiety response. In some people it might cause a decrease in heart rate depending on dose. In terms of interactions with other organs, I mean, when you ingest cannabis or cannabis products, they are, of course, processed by the liver. But as Dr. Fitzcharles mentioned, some of those interactions are theoretical. I think the main one that we know of in terms of the liver is that when people are taking high doses of CBD, especially when they're taking other anticonvulsant medications, as we see in the clinical trials with Epidiolex, the FDA-approved CBD product, that they can get elevated liver enzymes. And that can sometimes be problematic, can be a sign of liver damage or of oncoming liver damage. So I think that's a space that especially is important to monitor, but how that ties into the context of like disease modifying drugs, for example, I think we're still more in the theoretical side of things, unfortunately. So yeah, it's one of those things that it's a lot of poking around in the dark, unfortunately. Dr. Fitzcharles, was that your impression as well?
Sure. I wonder, perhaps I just want to add a little extra to that. And we usually, if you've taken cannabis, you have what we call vasodilatation. So if you go on the internet and you look and ask for pictures of people who've had cannabis, they've got red eyes. So there's vasodilatation, which causes the blood pressure to drop. But the coronary arteries and the arteries of the heart react differently. And with a moderately high dose of cannabis, there is vasoconstriction of the coronary arteries. These coronary arteries react differently. And there's now increasing patients coming into the emergency rooms who are using cannabis, not necessarily medical cannabis, more recreational cannabis, young people having acute coronary events as well as cerebral events. So just to remember that although we think that it dilates blood vessels, it's going to open up blood vessels, everything's going to go smoothly. No, it has the opposite effect to the coronary arteries. And we've seen a number of young people in our pain center who have had no other risk factors for coronary artery disease. In the last year, we had 3 young gentlemen who were using medical cannabis and had myocardial infarctions without any other risk factors. So it's something just to keep in mind.
Yeah, and that actually leads me to my next question for you, Dr. Fitzcharles. Like, is it safe for kids and teens to use CBD oils or gummies?
So, I'm a really strong advocate that we should not be using gummies and we should not be using brownies. That is not the way that we should be taking medications. So number one, so no. Number two, having gummies and brownies in the house, a child is going to eat it. And children are admitted to the emergency room taking these agents. So very, very concerning. This is children just accessing the agent that the parents have had. As I mentioned, the brain continues to develop until you're 21 or 25. We have great concerns. What we do know is that THC, or recreational cannabis, is an addictive substance, particularly if it is used every single day from adolescence. So the younger you are when you start using recreational cannabis, the more likely you are to develop a dependence, something like 25 to 50% of people. We honestly do not know what will happen to our young patients with ankylosing spondylitis, or the young girls who are 15 years old with fibromyalgia. if we start them using cannabis, even if it's a little bit of THC, when they're 18, what are they going to be like when they are 40? We don't know. So I think we have to have extreme caution for young people.
So generally earlier you had mentioned above 25, right? Is kind of the threshold. No, but you're not recommending
Right.
under 25.
Right. So, and that is based on the science of the development of the brain. And the brain starts developing in utero, and the whole circuitry of the brain finally matures only in the early 20s. And that was the reason why the Canadian Rheumatology Consensus Statement or position statement brought down 25.
Okay. All right. That's very helpful. I know there's always a lot of questions about that. And like you mentioned, there's a lot of young adults and teens who have fibromyalgia or lupus or anything like that, that you're trying to manage pain and is this safe or not? So not under the age of 25 is the recommended.
So could I ask Dr. Boehnke what his comments are on that?
Sure. I think that generally fits with my sensibilities about this. I will say as well that, you know, if somebody, say, is considering an opioid versus CBD in that kind of youth population, I know which one I would prefer, you know, that adolescent to be taking. Like CBD is probably better for them to be taking than an opioid at that point in time. So I think there are contextual factors that we should be considering. But I agree with that as a general guidance, and otherwise it gets into those very person specific harm reduction. What are they going to do instead? Kind of context. But that's all I would add.
Yeah. Thank you. And that ties into our next question. Somebody asked Dr. Fitzcharles, my pain clinic doctor is trying to make me choose between medical cannabis or narcotics. He said there's now a law where both can't be used together any longer, and I must choose one or the other. Is this true, that it isn't safe to use both at the same time?
I think that doctor needs a little bit of education. One. Number two, Dr. Boehnke has shown very well in his study that patients who've been on opioids, who have been introduced to cannabinoids, not everyone, but some of them are able to reduce their opioids, but these were patients on a combination of medications. What we also know is that pain is incredibly difficult to treat. And we have no magic bullet for pain. We do not have the magic treatment. And many a time when we are managing patients with chronic pain, be it remaining pain from rheumatoid arthritis or fibromyalgia or associated nociplastic pain, we often use a mixture of medications, but hopingly in a low dose and hopingly not to have side effects. So I think that poor doctor needs a little bit of education.
Well, that brings me to, I know a question many patients probably have. Not all doctors are as open to talk about this like you are, Dr. Fitzcharles, right? So when I go to my doctor's office, if I want to broach this topic of, hey, I want to find a way to treat my sleep without having to take a sleeping pill, I'm thinking and considering trying CBD, and your doctor shuts you down right away. How would you suggest a patient respond to that, and a best way to maybe approach and communicate what they are wanting to explore with their doctor?
Right. So I think what we're doing is we're dealing with personalities, and we really want to be respectful of each other. And open dialogue is the most important factor. And I really take exception to a healthcare professional who just says no discussion about this. That's unacceptable. And I think that probably reflects the insecurity of the healthcare professional, or maybe the lack of knowledge, or maybe a personal bias. If you are unable to enter into a respectful dialogue with your healthcare provider, I think that's not a very good therapeutic alliance, and I wouldn't know how to deal with that. Dr. Boehnke,
Yeah, I mean, I think you put it beautifully. Like, that is not a therapeutic alliance. In my mind, that's a situation where I might say to myself, gosh, if I try this another time and I get the same result, perhaps this means that this is not a good fit for me. In terms, maybe I need to find another healthcare provider, one whose personality is better aligned with mine, one who has more openness and is less authoritative and telling me how I need to deal with my body and my needs. And who's also willing to both educate me as a patient and be educated by me as a patient, and as a person. So yeah, to me, that's a red flag. And I think you put it perfectly beforehand, of saying a lot of people are keeping their heads in the sands like an ostrich. And I want somebody who's looking out with both eyes open.
so
Yeah.
just to add something about being a clinician, I've been in practice for many, many years, and patients with rheumatic diseases are a patient for life. So I've looked after patients with rheumatoid arthritis for the last 40 years, and I look after a lovely gentleman who was a young delinquent 18-year-old man with rheumatoid arthritis, and he is now an older delinquent principal of a high school with rheumatoid arthritis. So our patients are going to be patients for life, and we really do need to have a good therapeutic relationship.
Yeah, I couldn't agree more. I know I am fortunate to have the great relationship that you're describing with my doctor, and can say anything. And I know not everybody does, but definitely you're not stuck with the doctor, right? You can interview them because, like you said, they're your partner throughout your journey. So another question we want to get to is, are pain specialists more comfortable working with patients on medical cannabis than perhaps maybe a rheumatologist might be, or a primary care physician? Either one of you want to take that one?
I'm happy to go first. To my knowledge, I think it's mixed. I think some pain specialists, just like some rheumatologists, are realizing the genie's out of the bottle. Cannabis is something that my patients are using, and I need to learn about it. And if I see that even though there's this lack of evidence, if my patient is responding well, then I'm in an open dialogue and working with them. But I've also, seen clinics that are pain specific clinics that say, if you use medical cannabis, you cannot fill your other prescriptions here. And we will drug test you. And if you have a positive drug test and it keeps on happening, you have a positive THC drug test and it keeps on happening, we will not let you come back to our practice. And that still happens today in 2021. So I can't say I've looked too deeply into the literature to see if there's that variability across specialists, but that's just what I've seen anecdotally. Dr. Fitzcharles, do you have any sense of that?
So certainly in Canada, we surveyed the rheumatologists a number of years ago about their comfort regarding their knowledge of cannabis, etc. And the average rheumatologist in Canada does not feel confident regarding their knowledge, and this was a few years ago, and I don't think it's changed very much, do not feel totally confident about their knowledge or even their competence to be managing medical cannabis. So a lot of medical cannabis in Canada is being managed by family physicians. And a good family physician is a wonderful colleague to have.
Yeah, and huge differences obviously in healthcare systems between here in the U.S. and Canada, and it seems like the Canadian have a position statement when it comes to this. Is that something, Dr. Boehnke, you foresee with research that's currently going on, that there might be something that might come out of that, where research is coming out and we are trying to it's taboo to talk about it. There's a stigma attached to it. Are we going to say, well, actually research is, are we going to get to that point that research might support that physicians can talk about it more and feel more comfortable about it?
Yeah, I mean, honestly, I believe that the research is there now for physicians to be able to have those conversations. I mean, Dr. Fitzcharles and her colleagues put out a position statement. People in countries all over the world are putting out position statements with regards to cannabis. I think it's just a question. One, there's the political background in the US that is unique in that we have cannabis as a Schedule I drug that is criminalized. And I think that probably is driving the fear of putting out these types of position statements more than anything else. And that's pretty alarming to me, especially when we know that that designation is based not in science, but in typically racist and xenophobic politics. So I think that's something that we need to change. And I think that I'm hoping that some of these medical societies will start putting out this guidance regardless, because we have enough knowledge to adequately guide patients as we would with any other medication. We don't have the same type of strict dosing regimen, but we know that every patient who is using cannabis, they're figuring it out for themselves. And even with an FDA approved medication, there is an element of that. I mean, I'm put this out to the audience. How many medications have you tried and then had them not be helpful?
Right.
Again, you live in your own body. Your body is unique. You respond to some things and don't to others. So
Yeah.
I think it's a real missed opportunity, and one that I hope we do better on scientifically and in the healthcare profession as well.
Yeah, and one of the reasons that the Arthritis Foundation even approached, talking about CBD publicly is because we did a survey, and there were a lot of people responded, around 2,600, I think, people responded saying, yeah, I've tried it. And like you were saying, Dr. Fitzcharles, earlier, no, I didn't tell my doctor about it. And luckily, fortunately for us, both of you actually helped contribute to putting together that CBD guidance for adults with arthritis, because it's a scary thought that people are trying and don't have the guidance, or maybe don't feel comfortable talking to their doctor about it. So we so appreciate you guys coming on and helping educate and guide everybody as as they try to find different ways to manage their arthritis pain. I think we have time for just maybe two more questions, but one thing, you said here in the US, yes, there's lots of politics behind it all, and healthcare. But one thing I think a lot of people think about when they hear medical cannabis, and we're saying cannabis versus medical marijuana because for a variety of reasons, right? There's a stigma attached to that. But if you're someone who wanted to take it and try it to help you with your sleep, and like you said, if we can manage our sleep, maybe our pain will be better, right? And you have family or friends who look down upon that, right? That, oh, you're doing that. No, you're just doing it to have access to cannabis and get high. How do you respond? How can somebody respond to that? Like, how would you coach somebody to say, this is why I'm taking this, or for what reason?
So I've talked to many people who have had these types of conversations. I've had these types of conversations myself, and I think that honesty, openness, and willingness to respond to people's questions is really important. So, there are some people whose minds you cannot change, but I think the more that you as an individual showcase how you're doing these things in a responsible way, that you show how you are using this as medically as possible and talk clearly about the reasons why you're using it, not like, oh, I have pain sometimes, so I smoke joints all day. Like that's not that's not necessarily a good explanation, but saying I'm having a lot of trouble sleeping. I was trying some different sleeping medications. I did not like the way those made me feel. I had a lot of cognitive fog, difficulty doing the things that I needed to do the next day. I tried using this medical cannabis product. I have some tincture before bed. I don't get high, but I really have a more refreshing night's sleep. And then I'm able to do what I need to do a lot better. You know, that kind of changes and reframes that conversation in a different way. Again, there's some people who, you know, it doesn't make sense to talk to about, but I mean, people don't talk about every aspect of their lives with their family anyways. So I think there's also a question of whether you need to disclose it to every family member in your life. And then being judicious and thoughtful about how you do that is a really important way to go.
Yeah. Do you have anything you might want to add to that, Dr. Fitzcharles?
So just to add that I think that probably 20 years ago, there was a stigma about using cannabis or marijuana, which is called on the street. As legalization has evolved in many countries, I think the stigma is slowly reducing. And I think that people, and certainly with the advocacy for the need for cannabinoids as a therapeutic agent, it's slowly filtering into the mindset of people that it's not such a stigma. You know, no one complains if I have a glass of wine with my supper. It's just that's normal. But you know, at the time of prohibition, many years ago, you couldn't have a glass of wine with supper. So I think that the stigma is slowly reducing, and that's probably going to be a very good thing for our patients.
Yeah, definitely. No, you're not wanting to feel judged and about what you're doing to manage your pain. And as a patient myself, like, you know what, I almost don't really care what you think about how I manage my pain. It's what works for me personally, because I am the expert in my body, like you said, Dr. Boehnke. One thing, Dr. Fitzcharles, I know, since obviously you are an expert in this area, do you have patients who are using medical cannabis, and do you guide them in the dosing regimen with it?
Absolutely, absolutely. And I'm very, very happy to be a partner in their medical care. So I believe that particularly as a rheumatologist, I'm not an expert in everything, but I look after their bone health. I will look after their cardiovascular health. I will recommend that they don't smoke, and I will do the best I can for their pain management. And if cannabinoids have proven to be a good thing for a particular patient, I'm more than happy to manage their care.
Do you have some advice on how you would tell somebody to monitor the effects of it if they decide to start low and go slow and try it out for managing a certain symptom?
So like every medication that we use, you will make sure that the patient is aware of the side effects that we would be looking for, but also we really want to see a positive effect. So just to continue to take a medication and say, well, I'm not sure that it's really doing anything for me. I like to set goals with the patient and say, well, what do we hope to achieve with this treatment intervention? And if we've set those goals together, it's much easier at the next time we meet to say, well, okay, we wrote down that you wanted to have a good night's sleep. So has that worked? And I think it's really just having a good open dialogue.
Yeah, thank you. Do you have anything you would want to add to that, Dr. Boehnke?
I think that that's a really nice way of putting it. I don't think I'd have anything to add.
Is there a time frame though? So if I'm going to try a tincture to help me sleep, is there a time frame that I should try to target for to see if it's having an effect? I mean, clearly it's not going to be overnight. So is there a recommended time frame that you would suggest to somebody if they were trying to improve sleep?
So we know cannabinoids rarely are out of the system. They deposited in the fat, but the effect of the cannabinoid probably only lasts maybe 18 hours, maybe 24 hours. If we're looking at sleep, you will really know an answer within a week or two. If we're looking at pain, it might take a little longer because, again, we really emphasize start very slowly because we really are concerned that we do not want to induce side effects. So I would say sleep you'll know fairly quickly. The tiny dose doesn't do anything, maybe add a little bit more, but pain maybe a little longer.
Okay, that's
Yeah,
helpful.
I totally agree. I think especially if the pain is inflammatory in nature, then that can take quite a while to see some effects there as well. And I will say I have heard people with sleep, like the classic story I hear of somebody who's using cannabis for sleep and sticking with it is, gosh, those first 2 nights I used it for sleep, I slept better than I had in ages. So I think there is quite a range, anywhere from a couple days up to that couple weeks, for figuring out that with pain. But I will say as well that it is going to be to a certain extent a moving target with these symptoms as time goes on, because you may not be able to get the same product again. You may have a different symptom that becomes more pressing and important as time goes on. So anxiety being more important than the physical sensation of pain, or sleep, trumping all again, and the thing that you're using for that not being helpful. So just to put that out there.
Yeah, thank you. I think managing arthritis and chronic pain in general is like a moving target to try to find the thing that works. Some days it works and some days it doesn't, right? So definitely open communication with your doctor. Shared decision making is important, but always making sure that you're communicating with your doctor what you are looking to address as far as symptom management, right? So we don't want to take any more of your time. We respect the time you've given us already, Dr. Boehnke, Dr. Fitzcharles. Thank you so much again for lending your time and your expertise. If you look up research on chronic pain and arthritis, you will find both Dr. Boehnke and Dr. Fitzcharles' names come up on that research list of research articles available to see. So thank you. We are so fortunate to have your expertise at the Arthritis Foundation. Thank you.
Thank you. It's been a pleasure.
Thanks so much for having us.
Yes, we look forward to it. And I'll do one more plug for Dr. Boehnke, and that the podcast episode just came out yesterday on the Live Yes with Arthritis podcast about medical cannabis and arthritis. So if you haven't tuned into that, check it out. Download that anywhere you get your podcasts. But before we sign off for the night, just want to provide a reminder that we do have several resources and patient education events coming up to help in managing your arthritis. I know diet is a hot topic. Everybody likes to see what they can do and control when it comes to diet. So we have a webinar on plant-based diets, small changes, big impact, on February 16th. Hopefully you can join us for that. It is from 6 to 7:15 p.m. And then we have one coming up on COVID vaccines and arthritis. Everybody is talking about vaccines and when can I get it and is it safe? So especially for our population of people with arthritis, check that out on March 9th from 6 to 7:15 p.m. as well. We'll have another webinar coming up. The Live Yes with Arthritis podcast, again, is available anywhere you get your podcasts. We have a variety of topics, including medical cannabis and arthritis that, like I said, just came out yesterday. And if you have questions and need some help, our helpline at the Arthritis Foundation is there for you. Visit us at arthritis.org/I-need-help. So thank you guys for joining us. You can register for these upcoming webinars coming up at arthritis.org/webinars. And if you haven't already, get connected. There isn't anything more powerful in your journey with arthritis than connecting to a support group of people who understand your pain and what you are going through. Our online community forums can also connect you to experts and some other peers, including healthcare providers, to ask questions and share your experiences. We also have virtual support groups and in-person groups once safety allows with the pandemic, but connecting with others virtually through our support groups might help you feel more connected to people who understand what you're going through and, learn tips from each other. Learn more about those virtual support groups in the online community at liveyes.arthritis.org. We also have a Women in Chronic Pain roundtable coming up on March 4th. It's another patient education webinar. You'll want to tune into that, and there'll be a Facebook Live event as well later in March around the same topic of women in chronic pain. Our Insights program, like we mentioned at the top with the video when we got it to play, take just 10 minutes. You providing your insight on what it's like for you to live with arthritis on a daily basis really helps to inform what we do for content like programs like this. So managing pain or whatever the issues you have, it's important for us to know what is affecting you so we can help provide resources and tools to help you manage your arthritis. If you can take a few minutes, go to visit arthritis.org/liveyes/insights to take that survey. As a closing reminder, please note that in a couple of days, you should receive again a survey asking you about tonight's experience. Please take time to fill out that survey and honestly tell us what you think, and we can better serve you in the future. Your feedback helps us improve all of the educational events that we provide and organize for you to help with your needs and wants, and hearing from you is the best way to help us figure out what we need to put out there for you. Thanks again for joining us tonight. I hope you learned as much as I did, and just remember, talk to your doctor, open communication, and make sure you are doing the best for you, and you are the expert in your own body. So take care, everyone, and have a wonderful evening.